Morning, everyone. I hope everyone hears me okay. So I'm Meshal, I'm one of the PGY5s in cardiology. I have got nothing to disclose. Just wanted to go through the learning objectives for today's talk, which includes an overview of the echocardiographic assessment of mechanical aortic and mitral valve, review some complications, but not all, that are associated with those valves, and compare various imaging techniques in assessing those valves as well. So first off, I thought we'd start with a case. We have a 38-year-old gentleman with a woman's history of shortness of breath on exertion. He has a past history of rheumatic heart disease with a previous mechanical mitral and aortic valve and a previous tricuspid ring. Those surgeries were done out of Canada. He also has GERD and anterior disorder. He's on the following home meds, including aripiprazole, gabapentin, topiramate, trazodone, and warfarin. There is some interaction that I wanted to just note here between topiramate and warfarin. The topiramate combo can actually reduce the effects of warfarin. From a history point of view, he's been having one history of worsening shortness of breath. He's been in and out of hospital being managed as pneumonia. In terms of medication compliance with his warfarin, he tells me that he's been having difficulties managing his INRs in the last 2 years due to frequent travel. He has no other infectious symptoms or sick contacts. On examination, his vitals were stable. Blood pressure was 103. He was on room air. He did have findings of volume overload, including decreased airentry at the bases with some crackles and elevated JVP. And he had a good mechanical first and second heart sounds in keeping with his valves that were not muffled at the time. And a grade 2 systolic ejection murmur at the left lower sternal border and apex. And he also had a diastolic murmur at the apex. He had no lower limb. His lab work are overall unremarkable. His hemoglobin was stable at 135, no white cell elevation. Lights were fine as well, with a normal creatinine and a decent troponin, and an INR that was actually therapeutic at 2.63 at the time. So that's his 12-lead EKG. Overall, it looks benign. It's sinus rhythm with some biatrial enlargement, some maybe antiovesicular block, and some LVH. But overall, there was no concerning finding on that 12-lead EKG. So first off, we started with some imaging for this patient. We got a chest X-ray, which was this. And we can see overall that there's some small pleural effusions bilaterally. We can see there's 2 structures in the heart. And also there's some pulmonary edema as well. I just wanted to go through how to differentiate, or helpful ways to differentiate aortic mechanical versus mitral in this case. And usually if you can draw a line from the right cardiophonic recess to the left atrial appendage, the valve above is usually the aortic valve that points towards the LVOT, and the valve below is actually usually the mitral valve that points towards the apex. And then I added his baseline TEE before being admitted. And that's his echo. So overall from here, you can see that, the walls are moving fine. Ejection fraction looks overall normal. There's some septal motion consistent with post-surgical state. That's some color Doppler over his valves. And then, so his peak and mean gradients at the time were 9 and 3.4. That's from for his mitral valve. And the Vmax was 1.23 at the time. So overall summary of his baseline echo was mechanical mitral valve with peak and mean gradients of 10 and 3. His aortic valve had mean gradients of 26 and 15 at baseline. And he had some moderate PR and normal RVSV. So he was admitted to the hospital, and this was his admission echo. So we can see here in the 4-chamber view, there's some flow acceleration or flow turbulence across the mitral valve. And when we took his mean gradients, his mean was actually 28 with a max of 40 and a Vmax of 3.17. So overall, the summary of his echo at the time was an increase in his gradients of mean of 28, peak of 41, dilation of his RV, severe TR from moderate previously, and an RVSV of more than 60 compared to normal previously. So at this point, we were looking at other imaging modalities that can help us differentiate what's actually happening and what's the cause of this elevated gradients. So in this case, a TE can be sometimes, or most of the time, very helpful in trying to differentiate or look at the leaflet motion when TTE is not clear. Senior fluoroscopy is helpful, and also MRI can be helpful in bioprosthetic valves and not really mechanical valves, because there's a lot of artifact with the mechanical valves themselves. So we're going to stop with our case for a bit. We're going to go over some echo findings or assessments of mechanical aortic and mitral valves. Then we'll go back to our case. So mechanical valves are usually three types that are commonly used: the ball and cage on the left, the single tilting disc in the middle, and then single bileaflet on the right. This is an image from the guidelines, actually, showing the image in the middle are the valves opening during diastole and TE, and the images on the right are their physiological regurgitant jets. So, I'm sure a lot of people are aware of this, but there are some important information that we need to collect before seeing the patient or before starting our echo assessment. That would be the date of valve placement, the type and size of the valve, the height, weight of the patient, so we can index things to his body surface area and see what symptoms they have and their blood pressure and heart rate, because they can affect his gradients. Echo is very helpful in assessing the opening and closing of the discs and presence of thickening, calcifications, abnormal echo densities, and then also assessing the valve spring integrity and stability. When it comes to aortic valves, very similar to what we look for in a regular aortic valve, we look at the peak and mean velocities. Peak and mean gradients, the max velocity. The contour of a jet is very important when assessing mechanical valves. The DVI, estimated orifice area, and look for any regurgitant jets. And of course, we do our other complete assessment with LV function, RV function, and so on. I just wanted to note here that it's very important to look back and see what the manufacturer's expected gradients are when it comes to mechanical valves. These are actually in the guidelines, just to see what the normal range is for each specific valve in terms of gradients and velocities. So mechanical valves can get obstructed or stenosed, and in this case, this can be caused by thrombosis, pannus, valve deterioration, patient processes mismatch, which is a high gradients in a normal valve, effective endocarditis, and calcification as well. In terms of Doppler parameters, I think from reading the guidelines, they are very helpful or most helpful in assessing these valves. I highlighted the normal and the significant stenosis. I wanted to highlight that the jet velocity contour for a normal mechanical valve is usually triangular and early peaking, with a short acceleration time of less than 80, peak velocity of less than 3, and a mean gradient of less than 20. And a significant stenosis, we usually have a rounded symmetrical shape with an elevated acceleration time, acceleration time, ejection time of more than 0.37, high peak velocities, high mean gradients of more than 35 as well. The part below is for TAVI valves, which we won't talk about today, so I'll just left this for reference. And then this is actually from the guidelines as well, which I actually really liked. If you have a prosthetic valve with a high velocity, you look at the jet contour, and if it's early peaking, triangular in shape with a short acceleration time, slightly normal. If it's late peaking, symmetrical, rounded contour, it's with a delayed acceleration time, it could be abnormal. We then do our DVI, and then we basically, the DVI is low, it can be indicative of stenosis. This is also from the guidelines, which I really like. This is actually from a tissue valve and not, no, actually a mechanical valve, apologies. And then the top is actually a normal mechanical aortic valve, and the bottom one is actually one that's stenotic. What I wanted to highlight here is the images on the right, which are basically in a normal mechanical valve, the jet is triangular with a short acceleration time. In this case, it was 76. And a low velocity that's not high. In this case, it's 1.8 meters per second. And a valve that's stenotic or obstructed, it's more a rounded contour. Oh, my mouse is actually there. Yeah. The contour is rounded, symmetrical, and a delayed acceleration time. In this case, it was 127 with a high velocity of 4.1. We then move on to regurgitation. At this, here, when it comes to these valves, we look for intra and paravalvular regurgitation. Having a good sweep of the valve is very important because there are some jets that can be missed if we don't do a proper sweep. Otherwise, the limitation here is there's a lot of acoustic reverberation from the valve and shadowing from prosthesis that can limit our assessment. And in this case, TEE can be very helpful. And then the basics or the Doppler methods for assessing severity in aortic regurgitation are not usually effective when it comes to assessing prosthetic valves. The causes can be paravalvular leak, infective endocarditis, structural failure, thrombus, pannus, or distance. So again, just here. So looking at this image here, this is actually also from the guideline. When assessing for regurgitation, usually the structure or the way the mechanical valve looks is usually abnormal. So saying that, we mean the valve can have some abnormal rocking, or that can be indicative of dehiscence, abnormal closing of the discs that could be a cause of his regurgitant jets. The LV is usually dilated with a large width of the central jets, or vena contracta that's more than 0.6. Usually the AI deceleration time is usually very short, less than 200, with a dense CW. With a dense CW jet and a hollow diastolic reversal and the descending aorta. And of course, if you get a piece of shell, we do our parameters here to get the regurgitant volume. This image here illustrates, this is actually from the guidelines. At this point, this is actually a tissue aortic valve. Image on the top left shows us there's a small vegetation on the valve, or some lesion here just on the valve. In the middle, we can see a large regurgitant jet back into the LV. And here, when we did the AI deceleration slope, it was actually pretty short. In this case, it was 160 milliseconds. This patient also had aortic stenosis or obstruction of the valve. His max velocity was around 5 with elevated gradients. And then here, when we look at the thoracic aorta, there was some reversal, diastolic reversal, and also the descending aorta had some reversal as well. These are all indicative of severe AI, and of course, the obstruction as well of the valve. So we'll move on to assessing mechanical mitral valves. In this case, the bileaflet valve is usually the most often used. I haven't seen any other valve being used, to be honest, other than that. The estimated orifice area varies depending on the valve, but usually between 2 to 3 centimeters squared. The mean gradient also varies, but it's depending on heart rate, but usually 2 to 3 millimeters of mercury, and some smaller valves can be 5 to 6 at physiological heart rate. And in this case, we use the continuity equation to actually get the mitral valve area. The Doppler parameters are similar to what we usually do when we assess mitral stenosis. We get the peak early velocity, mean pressure gradients, heart rate at the time, pressure half time, DVI, and of course, other regular echo stuff like LV function, RV function, and so on, and PA pressures too. And things that can be indicative of significant stenosis would be a peak velocity that's elevated, more than 2.5, a mean gradient that's more than 10, a VTI, the prosthetic valve over LVOT of more than 2.5, and an estimated orifice area of less than 1, and a delayed pressure half time. In this image here, we have a mechanical valve in the mitral position. One of the discs are not opening adequately during diastole, and some flow ileus here in the top right image. And then the image in the bottom, we can see basically a delayed, pressure half time in this case. At that time, I think this patient had a gradient of mean gradient of 29, a heart rate of 86, with a peak velocity here of more than 2.5, which we talked about earlier, indicative of severe stenosis. And then the 3D images here, we can see there's two, masses/lesions attached to either side of the valve. and one of the discs is not opening adequately during diastole. And finally, we move on to prosthetic MR. Usually limited also by having a lot of acoustic reverberations and shattering from the mitral prosthesis. But things that can be indicative of a significant MR would be a dense CW jet, elevation in E velocity of more than 1.9 milliseconds, a low systemic output or VTI of the LVOT despite the very snappy hyperdynamic LV, elevated DVI, and elevated PA pressures as well. So things that are great and suggestive of significant MR or prosthetic MR would be peak velocity more than 1.9, the LV the VTI, a mean gradient of more than 5, and a TR velocity of more than 3 as well. Saying all this stuff about TTE, you often need a TE to adequately assess these valves. And that could look for mobility of the discs, making sure everything's opening okay, presence of vegetations or thrombi, and parallel or intravalvular regurgitations as well. It can also sometimes help us differentiate between pannus and thrombus, which we'll talk about in a bit. Patient prosthesis mismatch is basically where the estimated orifice area or effective orifice area is too small relative to the patient's body size. In this case, the EOA, the leaflet morphology, the opening of the valve, and mobility of the valve is all normal, but the index or estimated orifice area is small for the patient's body size. The concern here, you have high gradients and functional stenosis. Aortic patient prosthesis mismatch has been associated with reduced short-term and long-term survival, higher rates of heart failure, less regression of LV hypertrophy, and faster development of structural valve dysfunction have been reported. And then the gradients actually have been shown to increase exponentially when the indexed estimated orifice area is less than 0.8. I wanted to highlight here that patients with high BMI have different cutoffs for index orifice area because their values, when you index them to the regular parameters, they can technically be in the severe range when they're actually not. So therefore, when their BMI is more than 30, we go by cutoff of index orifice area of less than 0.55. So what about other imaging modalities? We'll talk about fluoroscopy and CT. Sinus fluoroscopy was one of the first non-invasive imaging techniques to evaluate these valves. They're easily applied for mechanical valves and limited for tissue valves. We can basically see the opening and closing of the valve discs and the angles with the open and close at, and also look for disc embolization or strut fracture. Image in the bottom left is a valve in the mitral valve position, showing that one of the discs is not opening during diastole. And the video on the bottom right showing a rocking valve, which is a big red flag sign in the aortic position from valve dehiscence. Moving on to CT. CT is very helpful in detecting masses and abnormal leaflet motion as well. It has the ability to differentiate thrombus from pannus and obstructed valves, depending on their Hausfield units. There was actually a paper in 2015 that looked at this, and they saw that Hausfield units of less than 90 can be more in keeping with thrombus, and more than 145 are more in keeping with pannus. And response to thrombolysis can be predicted when the Hausfield units is less than 90, and usually almost complete lysis obtained in masses less than 90. Pannus is a more chronic tissue ingrowth that leads to obstruction and often needs surgery. Thrombus usually has potential for treatment with thrombolysis in this case. It often can be hard to differentiate the two, which I'll show you later on when we go back to our case as well. Image on the bottom right is just shows a mechanical valve with pannus scope on it. Moving on to pannus, still on pannus versus thrombus. Thrombus is usually due to clot formation, as you know. It's usually shorter time after valve implantation and commonly associated with suboptimal anticoagulation. It's more commonly located in the atrial side of the mitral prosthesis and aortic side of the aortic prosthesis. And it also can sometimes result in greater leaflet motion restriction. On the other hand, pannus usually is in the ventricular side of both mitral and aortic, and it's due to fibroblast perforation and collagen deposition in this case. And it's usually longer time after the valve has been implanted. Okay, so next we'll move on to valve thrombosis, how we treat it, and we'll go back to our case. So the rates of mechanical valve thrombosis is usually between 0.1 and 5%. The tricuspid and mitrals are more common than aortic due to the low velocity of flow usually around these valves. Higher rates in the first 3 months and usually associated with inadequate warfarin treatment and can be associated with thromboembolic events like TIAs, strokes, or valve dysfunction. It can present in an acute and subacute way. Patients can have symptoms of heart failure, TIA or stroke symptoms, infectious symptoms if there's infective endocarditis, and we have to always assess medication compliance in this case. Patients can also present with shock, and when you listen to their chest, they can have a stenotic murmur or muffled closing thugs. The diagnosis is usually, again, the key to the diagnosis would be elevated velocity through the valve and an increase in the gradients as well compared to baseline. And of course, you try to look for limited leaflet motion, attached mobile echodensities, consistent with thrombus, pannus, or growth in this case. The management can be surgical or thrombolysis, and that usually is a discussion between the surgeons and the cardiologists, and depends on available expertise, the risks of surgery, if there's any contraindication to thrombolysis, and clot size, and if the patient has concomitant CAD that needs revascularization as well. And of course, patient choice. With regards to TPA protocols, there's a low dose, long 24-hour protocol. There's also 6-hour protocols that actually work. And studies have shown that both have around the 90-95% success rates. So we'll go back to our patient. So our patient had a CT to try to figure out what's been happening, and we saw an immobile medial disc. And then when we got the CT, there was like a density here that we can see. This actually had a low Hosfield units, which is more in keeping with thrombus. This is a cine image of the CT. It's not a great video. I should have gotten a longer clip, but basically the medial disc is not moving, and the lateral one is moving, but not opening fully. The summary of the CT was a Hosfield unit of 80 to 90, and there's a non-mobile medial valve disc, and there's a hyperdense lesion on the inferior junction of the valve disc as well, measuring up to 5. And they said it's just suggestive of thrombus. So he underwent TPA because this was suggestive of thrombus, and his mean gradients came down to 24. Peaking mean went down to 24 and 13 from 41 to 28. So a lot better, but still not what he used to have before. So he got another CT, which shows that the lateral disc was actually moving better. So probably some of this was actually thrombus. The image on the left was the lateral disc. The right, was pre-TPA on the left. Apologies. Post-TPA on the left, pre-TPA on the right, and the opening of the disc was actually better on post-TPA, but still not normal, and still the medial disc was not moving okay. So he underwent the TEE at that time, which showed that the medial courier is still not moving all right. And again, no huge thrombus seen. We still have some flow acceleration through the valve as well. And of course, we can see the occluder as well. And this is 3D that shows the medial occluder is not moving. So mean gradients at the time on TE were 19, were max of 19, mean of 11, and showed similar findings. And then he underwent a repeat TPA to see if things can actually get better this time. And at this time, things were kind of the same, and we had the similar gradients with the TE post or echo post second round of TPA. At this point, the discussion was done with the team members and the surgeons, and ultimately the decision was made to take this patient back to OR, and he ended up having a mix of both thrombus and actually pannus. And that concludes my talk. So I hope this was helpful. And here we kind of just basically went through aortic, mitral valves and how we assess them in echo, and a small case as well, just to demonstrate that findings. Thank you for listening. These are my references.
Thank you.